The next one will be the slide, what we have seen on the last week. So that was the part what we have already seen. So this is the development of the male genital ducts controlled by the testosterone and of course the anti-Mullerian hormone. This is for the regression of the paramesonephric duct. And we have seen how the parts will develop, and the epigenital tubules give the ductuli afferentes testis here, and then this will form the communication between the rete testis and then the duct of the epididymis, and then this part will become very coiled here, and then this gives the epididymis. The continuation of it we call the vas deferens, and the vas deferens will be that straight part of the mesonephric duct. In the area of the mesonephric duct, small bud-like evagination will occur, and this will give the seminal vesicle. Its duct is called the excretory, and of course it fuses with the vas deferens, with the ampulla of the vas deferens, and then the last part of the mesonephric duct therefore will become the ejaculatory duct. Next to it, we see already an embryological remnant, which is related to the paramesonephric duct. It is exactly so that the paramesonephric duct, with its caudal tip, it reaches the dorsal wall of the urogenital sinus, where in the dorsal wall of the sinus, male genital tract, we will get the prostatic utricle as the remnant of this paramesonephric tubercle. The other one, which is also such an orange-like, orange-colored structure here, is the embryological remnant of the paramesonephric duct. And so this was the situation in case of the male. But in this case, we have already seen only one of the three accessory sexual glands, and this was the seminal vesicle, but we have not mentioned the prostate and the bulbourethral or Cowper gland yet. In case of the development of the prostate, we should mention the urogenital sinus. So we should do a quite short recap about the formation of the urogenital sinus. It will develop with the differentiation of the cloaca. Cloaca will divided into two parts by this growing urorectal septum here, and then we will get a ventral urogenital sinus. It is the primitive urogenital sinus in this phase, and then we will get the dorsal anorectal canal. And of course, the urorectal septum grows further caudally, and then it will separate the urogenital sinus from the proctodeum later here, and then we will have here the derivatives of this urogenital sinus. We will later also mention, so more times we will mention this urogenital sinus. It is very important that this is not part of the intermediate mesoderm anymore. This is a structure belonging to the endoderm already. If we see the three main parts of the urogenital sinus, we have its upper part. It will give rise to the urinary bladder in both genders, and we will have its pelvic part. This is this middle portion, and we have the lowermost part. This is the phallic part here. And this pelvic part is now important for us because it will give rise to the prostate. Approximately on the 10th week, we will get some endodermal evaginations at the level of the pelvic part of the urogenital sinus, and here already we can see them here. So on the 10th week, we will have some solid prostatic cords developing from the pelvic part of the urogenital sinus. A week later, these solid prostatic cores will develop a lumen, and we will get already the later glandular asyni of the prostate. So this is only the glandular epithelium deriving from the urogenital sinus, from the endoderm of the urogenital sinus. And in this case, we should have also, of course, the muscular and the connective tissue components, so that the background tissue is a fibromuscular connective tissue in case of the prostate, which develops from the mesenchyme surrounding the urogenital sinus at this level. Already by week 13 or 14, the prostate starts its secretory activity. In case of the development, we can see or already in adulthood, in the slides obtained from the prostate, we could see an embryological remnant, what we have already mentioned here. This is the utriculus prostaticus or prostatic utricle, which was the embryological remnant of the paramesonephric tubercle, and it is visible in the adult prostate in the section of it. So this is what you will see in case of the histology practice. So this is the development of the prostate. We have a gland that is the evagination, an endodermal evagination, and the other components, connective tissue components, will develop from the surrounding mesenchyme. If we then continue the discussion of the development, we should see the development of the female genital canals. And in case of the female genital canal, we should also mention the indifferent stage again. So this is what we have already seen. So this is the indifferent stage. At the end of the 6th week, we could not see any differences between the two sexes. In this case, on the left side, we see the male genital system, and on the right side, we see the female genital system. In case of the female genital canals, we do not have sorry, I should change my slide. We do not have these hormones, which have had a very important role in case of the male development. In this case, testosterone and AMH will not act on the development. Therefore, the mesonephric duct atrophies, and we will get the further development of the paramesonephric duct because we do not have anti-Mullerian hormone. These things happen in presence of estrogens, and here on this picture, in this picture, we can see the two ducts playing a role during the reproductive development. This one is the paramesonephric duct, is orange colored, is the paramesonephric duct, and then this blue one is the mesonephric duct. In case of the female development, this mesonephric duct regresses, it undergoes an atrophy, and the paramesonephric duct will develop further, and it will survive, and it will remain, and it will differentiate into further structures. This paramesonephric duct has three main parts. We have an upper vertical part, and it opens freely into the abdominal cavity, and this opening will become later the abdominal orifice of the uterine tube, and this vertical part continues in this perpendicular part here. So this crosses the mesonephric duct from anterior. Then we have here the last caudal portion here, and it meets with the similar structure of the opposite side, and these two caudal portions of the two paramesonephric ducts meet, and then they will fuse here. During the development, the ovary descends, not so pronounced like the testes did, but the ovary has also its descent. But it's of course it's considerably less than the descent of the testes, because the ovary descends only to a level which is just below the entrance of the lesser pelvis. But during this descent, it pulls also structures with with itself, and during this descent, these two portions, the vertical upper portion and this perpendicular portion, will or transverse portion, will um, be pulled downward, and they will give the uterine tube portions. The Codal portions here, which the two caudal portions meet and they unite to form the uterus plus the uppermost part of the upper part of the vagina, and this is what we will also mention. At the upper part of the vagina, we have a circular protrusion, and this will be the later fornix of the vagina. So during this development, of course, so here in the middle, at one time point of the development, we have a septum here, but normally, physiologically, this septum disappears, and we will have one cavity of the uterus. During the descent of the ovary, it will also pull the so-called genital ligament. This genital ligament is related to the male gubernaculum. In case of the descent of the testis, we have mentioned the gubernaculum, which has connected the testis to the anterior abdominal wall. In this case, we have also similar structures, and this is the structures corresponding the male gubernaculum. This is the caudal genital ligament here, going from the lower pole of the ovary in direction of the anterior abdominal wall, but it does not end there. I will explain why. But first, we see the cranial genital ligament here, which connects the ovary to the diaphragm. And this cranial genital ligament gives rise to the suspensory ligament of the ovary. This is what you have already studied from anatomy. Then the other one, the caudal genital ligament, which corresponds the female which could be the female gubernaculum. In this case, it goes from the lower pole to the in direction of the abdominal wall, anterior abdominal wall. It will give the proper ovarian ligament and the round ligament of the uterus. And of course, we know that the round ligament of the uterus does not end at the level of the anterior abdominal wall, but this is the structure in female which goes through the inguinal canal, and it descends to the major labia. In case of the remnants of this blue mesonephric duct, of course, we should also talk about the mesonephric duct. However, we know that it regresses, but we have some embryological remnant of the mesonephric duct. Two embryological remnants could be found in the area of the mesovary here. These are the apophoron and the parophoron, and one more structure could be seen. This is the Gertner's cyst here. This is also the remnant of the mesonephric duct, which originally has opened into the urogenital sinus on both sides of the paramesonephric tubercle, what we have already mentioned. If we see the further development. Of course, vagina also belongs to the internal female genital organs. And in case of the vagina, we have mentioned only the development of the upper part of the vagina. The original caudal tip of the paramesonephric duct is in contact with the dorsal wall of the urogenital sinus, as I have already mentioned. In the dorsal wall of the urogenital sinus, this connection has a stimulatory effect, and then we will get proliferation here, and then this is the cause of the formation of the Mullerian mesonephric tubercle. Continuous cell proliferation here, cell layer thickening here, and then this paramesonephric tubercle will become the cyanovaginal bulb here, and then we call it cyanovaginal bulb. Then if this proliferation is continued and we will get a thicker cyanovaginal bulb, we could call it vaginal plate. In books, we could have different terms for these structures. At the end, it's sure that we will have the vaginal plate. First, it is a solid cord without any lumen, but in the fifth month of the development, in the fifth intrauterine month, this vaginal plate becomes canalized, and then at the end of this fifth month, the entire vagina is already canalized here. But it does not open into the vaginal vestibule yet. It is closed by the hymen. So this hymen is composed of the thin endodermal layer of the urogenital sinus, plus we have some cells deriving from the vagina, and these form the together the hymen, and that is a border between the vaginal lumen and the urogenital sinus at this stage. If we see the next slide, in the next slide we will see these events from a lateral aspect. And here first we see this is the cyanovaginal bulb, which originates from the paramesonephric tubercle, and here we see the urogenital sinus. Then the cyanovaginal bulb thickens, and then it gives rise to the vaginal plate. And here we have also this urogenital sinus. And here at the end, of course, we have also this urogenital sinus. We are not at the end of of the development. And here we see the hymen, which closes the vagina in direction of the urogenital sinus. If we see the next slide, we can see that we could have very different forms of this hymen. Of course, in case of the imperforate hymen, it is not normal or it is not physiological, because it will cause problems during puberty when the blood would leave the uterine cavity. Of course, in this case, surgical incision should be done. But we can see many different forms of the hymen. Hymen will be torn during the first intercourse, and we will get only some remnants, only some small nodes on the rim of the entrance of the vagina. We have this fusion of the caudal parts of the paramesonephric ducts during the development. So this is how the uterus and the upper part of the vagina are formed. But of course, if something does not go properly, we could have malformations here. And in this case, we could have this malformation here. This is called the uterus didelphys, with generally it is associated with double vagina here. And then of course here the septum does not disappear in the middle between the two caudal portions of the paramesonephric ducts. We have a very slight indentation here in case of the uterus arcuatus. Of course, it will not cause significant problems. It's simply a small tissue piece in case of the roof of the cavity. Then this is called the bicornuate uterus, this one. This means that we have two horns of the uterus. It is the type when both horns communicate with the vagina. And we could also have this one, the uterus bicornis unicollis. It means that one of the two horns is rudimentary. In this case, it could be even dangerous because it could happen that the sperm cells, the spermatozoa, could go through the vagina and the uterus in direction of the uterine tube. There in the ampulla, they find egg cell, then fertilization happen. And then, of course, it is also possible that the blastocyst will be implanted in this not rudimentary horn, but it is also possible that the blastocyst reaches the other one, the rudimentary horn, and in this case, of course, we could get very dangerous, very serious problems, because here we do not have enough place for the development of an embryo, and then later for the development of a fetus. In case of these two, we have atresia. Atresia could affect the cervix. In this case, of course, we don't have communication between the vagina and the uterine cavity, or the atresia can affect the vagina. Of course, this is below the normally developed cervix here. If we summarize these malformations, we could emphasize two malformations which are quite common and very commonly diagnosed malformations. This is the uterus didelphys, when we have two horns of the uterus, sometimes or not sometimes, generally associated with double vagina. In this case, so this is a photo of an operation. Here you can see these two parts. Here the two horns here. Okay, or two parts, not, we do not call them horns here. And here this is a hysterographic picture. In this picture we can also see these two parts. This is an ultrasound. We see these two. And two horns. In this case, two not rudimentary horns, two complete horns here. This bicornuate uterus is generally normally visible in animals, but of course in us now we have only one uterine cavity normally if the development happens properly. Here we see also bicornuate uterus on this ultrasound. And here we have ultrasound picture. Here we have the right side, and here we have the left side. And on the right side, we see also a pregnancy here, a developing embryo here. Then we can summarize what we know about the role of the urogenital sinus in the development of the reproductive system, or just summarize the role of the urogenital sinus in the development of many structures. We, as I have already mentioned, we have three parts of the urogenital sinus. We have the upper part of the urogenital sinus, and which is of course here only this is visible here, and here we can see the other part as well. So this is the upper part giving rise for the urinary bladder in both sexes. Then we have the pelvic part here, and we have the phallic part, the here. The prostatic part and the phallic part together we call the definitive urogenital sinus. And this pelvic part will give rise to the prostatic and membranous parts of the urethra, prostate and bulbourethral gland in males, and the lower part of the vagina and the female urethra in females. The lowermost part, the phallic part, will give rise to the spongy part of the urethra and the glands around it. These are the so-called Littray's glands. In case of females, this phallic part will develop the vaginal vestibule, one together with another structure, what we will mention. And then we have some glands opening into the vaginal vestibulum. These are the major and the minor vestibular glands. So this is only a summary of the urogenital sinus. We should discuss the development of the external genitalia. We have here also an indifferent stage, like in case of the gonads and in case of the genital canal. So at each level, in case of the gonads, in case of the genital canals, and in case of the external genitalia, we have always this indifferent stage. This indifferent stage is visible here. Already during the third week, mesenchymal cells will migrate through the primitive streak in direction of the cloacal membrane, and around the cloacal membrane, they will find the structure. These slightly elevated folds, they are the cloacal folds. These cloacal folds unite anteriorly and they form the genital tubercle here. Later, these cloacal folds will differentiate into a ventral urethral fold and the dorsal anal fold here. And of course, the urethral fold is behind this genital tubercle, what we have already mentioned. On both sides of these cloacal folds and later on both sides of the urethral folds, we have elevated tissues and heel-like structures. Here they are the genital swellings, this here, genital swellings here. At the end of the 6th week, we could not see any differences between the between the developing external genitalia of both sexes. So we could not differentiate or distinguish between male and female at this stage of the development. If we see the further development of the male external genitalia, we can see what these structures will happen to. In this case, we see here was the genital tubercle. Here are already the urethral folds, but the genital tubercle will do a rapid elongation. And at this stage, we call it already phallus. And with this rapid elongation, the phallus will pull the urethral folds forward. Between the two urethral folds, we identify the urethral groove. This is the urethral groove. And in the depth, this urethral groove has the urethral plate. This has a lining from endodermal origin. And this is what we can see here. So if we do a section here, we could see here, so this groove means the urethral groove, and this is the epithelial lining, which is called the urethral plate. The tissues of both urethral folds will grow, and then these urethral folds at the end of the 3rd month will close over this urethral groove and urethral plate. From this urethral groove, hence, we will get the penile urethra. Here it is visible. This, of course, it means that these urethral folds simply close, but one lumen will remain. Here we can see these events, these phenomena from the side. And then in this case, here you can see this is the lumen of the penile urethra. But this lumen of the penile urethra does not extend to the tip of the penis in this area, because the most distal portion will not develop from this endodermal structure here, only to this point, because later ectodermal cells will penetrate into the glands here, and they will give rise to the most distal portion of the urethra. Here first we have a solid epithelial cord, but later cells in the middle will die by apoptosis, and therefore a lumen will be developed, and here we can see that here. And here we have here this dilated area. This is called the navicular fossa, giving the border between the part of the male urethra of endodermal origin and the other part of the male urethra, which is from the ectoderm already. So that area which is from the ectoderm has its epithelial lining of stratified squamous non-keratinizing epithelium. The other one, which is more proximal, which is proximal from that navicular fossa, having its endodermal origin, is lined by the stratified columnar epithelium. This is what you have already. Of course, the scrotal swellings here, and these scrotal swellings will also fuse, and they will fuse in the midline, and in the midline we will get the scrotal septum, where we have this raphe here on the surface. So normally they will fuse. Of course, we could also have some malformations happening during non-optimal development. In this case, we could mention these two malformations. Hypospadias is related to the previous picture. If the urethral folds or the scrotal swellings does not meet in the midline and do not fuse, if they do not fuse, we could have abnormal urethral orifice found on the urethral surface of the penis, or even on the surface of the scrotum. It is also possible that we have a long slit, because it is possible that the urethral folds will not fuse, and not only one small opening will remain, but a longer slit. In this case, of course, we do not have so many openings, but only one of them. But this picture shows only the possible sites where we could observe such abnormal urethral orifice. Or here, in case of this picture, in the picture, we could also see some possible points. In case of the epispadias, the other problem with the urethral opening, with the external urethral orifice, the opening of the urethra, the external urethral orifice, is found on the dorsum of the penis. It could be an isolated malformation, but generally it is associated with extrophy of the urinary bladder and with impaired closure of the anterior abdominal wall. Therefore, we could see here the urinary bladder, the mucous membrane of the urinary bladder, of course, with the disturbed anterior abdominal wall. Here we could also see a picture about the epispadias. If we continue, of course, we should say something about the development of the external female genitalia. Of course, in this case, we have also the genital tubercle and the urethral folds. But in this case, we do not have such an intensive rapid elongation of the genital tubercle, although we have one time point during the development when the clitoris developing from that genital tubercle is longer than the phallus in case of males. Therefore, we could not distinguish between the two sexes in this time point during the development, because the clitoris can be longer. Of course, the urethral folds will not fuse, of course, and the urogenital groove will remain. Of course, it will differentiate, and the urethral folds will give the minor labia, these, surrounding the vaginal vestibulum, which is formed partially by the urogenital groove, partially by the lowermost part of the urogenital sinus, as we have already mentioned previously. The genital swellings found on both sides of the urethral folds will also not fuse, of course, in the midline. They will become a little bit bigger, and then they will give rise to the major labia in this case. So this is the development of the female external genitalia. Of course, during this entire path, from beginning with the strigine until we reach the development of the external genitalia, we can have many problems, and not only starting with the strigine, but already starting with the meiotic divisions happening in the parents. And we can have many types of these disorders of sexual development. And these DSDs are very we can have many types of these DSDs. The most commonly diagnosed DSD is the Klinefelter syndrome. And in this case, we can observe a masculine phenotype. Of course, here we can see a photo about a patient suffering from Klinefelter syndrome. He has most probably 47XXY karyotype, which is visible here. So here we have one extra X chromosome. And with this one X extra chromosome, we can get, or we will get, many associated problems. These characteristic symptoms are that we have hypogonadism, so the testicles are smaller in volume, of course, leading to infertility. They have enlarged, these male patients have enlarged breasts. And of course, because of the small testicles and these hypogonadism, they have a lower serum testosterone level. Of course, it could be the cause of many characteristic symptoms. The most common cause is the non-disjunction of the XX homologues during the division. So if during the division these paired homologue chromosomes will not leave one another, two X chromosomes will be together. They will meet with an Y chromosome, which is carried by the sperm cell, of course, and then we will have at the end these 47XXY chromosomal karyotype, and it is visible in 80% of the cases, but it could be caused by 48 XXXY, or we could also observe a mosaicism when some cells contain XY. Hermaphroditism is also a group of DSDs. In this case, we distinguish true hermaphroditism and pseudo-hermaphroditism. The true hermaphroditism is an extreme rare condition. In this case, the patient suffering from this true hermaphroditism has a gonad where both ovarian and testicular tissues could be identified. And this gonad is called the ovotestis. We could have many different arrangement of these ovarian and testicular tissues inside the gonad. These are the possible things, but of course it is only for demonstration. You should not know that. Generally, in 70% of cases, the true hermaphrodites have a karyotype of 46XX. In case of the pseudo-hermaphroditism, the phenotype and the genotype will not correspond to each other, and we can distinguish male and female pseudohermaphroditisms. The most common type of female pseudohermaphroditism is this congenital adrenal hyperplasia. The congenital adrenal hyperplasia is a problem which due to an enzyme defect. Generally, this enzyme is the 24-hydroxylase. This enzyme is one member of the steroid hormone synthesis in the adrenal cortex. In the adrenal cortex, we have three layers. Of course, later you will learn the detailed histological structure of this adrenal cortex, but we have these three layers, and the problem with this enzyme affects two of these three layers. And the third layer, producing the weak androgens, will produce more androgen hormones. These are weak androgens. And from these weak androgen hormones, we will get more in case of this disorder. It causes almost no problem in case of males if we see only the overproduction of the androgens. Of course, it causes precocious puberty in male, but it causes virilization, intrauterine masculinization in female. In this case, of course, it is also it is only true for the problem caused by the overproduction of the androgens, because of the disturbed production of the other two layers producing the mineralocorticoids and glucocorticoids. Of course, we could have quite serious problems, and these hormones should be, of course, substituted. Then we have also the androgen insensitivity syndrome. In this case, the problem is the partial or complete lack of androgen receptors. Therefore, the tissues will become unresponsive, and they could not respond to the effects of the androgens. And these patients have XY karyotype. They develop their testes, but they will be born with typical female external appearance. It means that the external genital typical external area. To Therefore, they will not have the male internal organs. And they have also AMH because testis functions properly, and this AMH will cause the regression of the Mesonephric duct. They will not have uterine tubes and uterus, but they have a short vagina. And it is very important that the upper part of the vagina is missing, but the lower part, which is not from the Mesonephric duct, but from the urogenital sinus, remains, and therefore we have only a short vagina. Not only the formation of the internal genitalia is affected or disturbed, but the descent of the testes does not happen properly, and it can be either in the abdominal cavity or in the inguinal canal or somewhere here in the inguinal region. Here we see a female patient suffering from swellings in the inguinal region, and it turned out that inside she has two testes. And in this case, the testes have an increased risk of tumor formation, and therefore these tumors should be removed. We have other problem with the testosterone production. This is the 5-alpha reductase deficiency. This enzyme converts testosterone to dihydrotestosterone, which is a more potent androgen hormone, playing a very important role in the development of the external male genitalia and in the development of the prostate. And if this conversion will not happen because of the deficiency of the enzyme, the patient will have male gonads, but the external genitalia will be either female type or ambiguous external genitalia could be visible. The gonad dysgenesis is also an important group of the DSD, and in this case we distinguish 46XX or 46XY gonadal dysgenesis. In both cases we have streak gonads. It means that instead of having a normally developed gonad, only a fibrous tissue streak is visible in the abdominal cavity. Of course, we can compare this streak gonad with a normally developed ovary here. So we can have it with 46XX karyotype or 46XY karyotype. And this is in case of the Swire syndrome, what we have already mentioned. This Swire syndrome is caused by the point mutation of the SRA gene. In this case, the testis development fails, of course, and instead of having the testis, streak gonad will develop. These patients have also a female appearance, and normally developed female external genitalia are visible in this case. Also, gonadal dysgenesis is visible in case of the Turner syndrome, and this is the syndrome what you have already heard about. This is the only one monosomy which is compatible with life. So this is caused by the monosomy of the X chromosome. The karyotype is 45X0. It is caused mainly by non-disjunction in gamete. We have second X chromosome. So here one chromosome is missing. So this gonadal dysgenesis is also very important. It is also associated with infertility. And these are the things what I wanted to share with you. And thank you for your attention.